Just the chair, I think.
Oh, the chair,
Yes.
yeah, thank you. Okay. What's my talk? Happy to take any questions at this point, and then we'll load up Jennifer's while we're waiting.
Here they come.
Yes.
First, thank you for taking the time and joining us here.
Yes.
Dr. Domes, I have a couple of quick questions to ask you. I had a radical...
Thanks, Murray, for the invitation to your guys' prostate cancer support group. This is just a wonderful venue, I think, to share together and to, from a patient perspective. Louder? Louder. Okay, louder, okay. This, I think, is a wonderful venue for you to learn from each other and to share experiences. And really, the prostate cancer, as I tell my patients, is a journey, right? It doesn't just end at the treatment. It's a survivorship thing. And that's what we're talking about tonight when we're looking at sexual dysfunction following prostate cancer treatments, okay? So, yeah, as Murray said, I'm one of the urologists. I'm a subspecialist in sexual health and infertility, and I also work with the new Physician Assistant Studies program as the academic director. And as said, Jennifer Bond is our new sexual health coach, who will introduce herself later and have a little presentation about our new initiative that's sponsored by St. Paul's Hospital Foundation, and Lucine is here, and we're grateful to have her as well. Just a little bit of a review, but male sexual function, as female sexual function, is complex. It's not just erection, right? Erection is part of it, but there's sexual desire, there's ejaculation, there's orgasm, and in prostate cancer treatment, all of these are impacted, right? So we'll focus a lot of our effort and discussion tonight on the erection piece, but just be mindful that the sexual function piece is complex. This was doing this earlier too. And when we look at erections, oh my Lord. And those of you that have had prostatectomy or radiation therapy, those nerves that go along the prostate are really critical for erections, okay? They allow the vasodilation to occur. They're sort of highlighted here. And those nerves, it's almost impossible to spare them fully, right? There is nerve sparing techniques, but in essence, you're gonna have a little bit of damage to those nerves, even in the best of surgical hands, okay? So that will impact the erections. The other thing that's important for erections, of course, is blood supply. And inevitably, with surgery and with radiation, blood supply is impacted, okay? So that's another way that the erections are affected. We talked about ejaculation. Again, the ejaculate volume, after you've had prostatectomy, ejaculate volume is 0. That's because the prostate and the seminal vesicle are both removed with the procedure. And even with radiation, we also see ejaculate volume go down and can also go to 0, okay? Because you get what we call atrophy or shrinkage of those glands, and they don't produce that fluid. So again, that's affected by both. And then hormonal therapy obviously affects everything. It affects not only the erections, but it affects quality of life, it affects libido or sex drive, mood, and of course, overall wellness. And again, it's a mainstay for treatment of metastatic disease, and it's also often used with radiation therapy for short periods of time. But it's also a big, big culprit of sexual dysfunction, right? And the thing that you have to know is that not all men will bounce back after hormone therapy, okay? Many do, but not all will to the same level as they were before. So we try, in urology, if we can try to avoid hormone therapy, we will, but it is inevitable for some patients. And then this is sort of where Jennifer and our share clinic idea comes from, but it's beyond just the biology of these things that we just talked about, because the diagnosis itself and the treatment and the dysfunction, as you see here from this sort of complex Venn diagram, there's also the psychosocial and relational aspects, which I think are even more impactful. And the sexual function with the partner, with the relationship, with the effect on self-esteem, and what you'll see later, what people consider being like a man or their maleness is highly impacted in prostate cancer treatment and diagnosis. So that's where we can't just treat with pills and treat with injections and treat with implants. We also have to think about treating the mind and the psyche and the soul. Okay, and that's where the Share Clinic comes in. And it's something in Saskatchewan I think we've been lacking, and so we're very, very fortunate to have this new initiative come forward where we're able to start getting there, and that I think will help greatly. This is a study that was done looking at patients who presented with prostate cancer at varying different stages of the disease. Okay, some localized disease, advanced disease, metastatic disease. And what you're seeing is that a great majority of patients, no matter where they present, are going to have a lot of concerns right after their treatment. Okay, again, the more advanced your disease, oftentimes you'll have that hormone therapy, so that'll be a double whammy. If you have more than one treatment, like hormone plus radiation or hormone plus radiation plus surgery, you're going to have more impact. But even in patients that have relatively localized disease with one treatment, you're still going to have huge amounts of effects, not only on the physical, as you see there, but also on the psychological. So things like loss of sexual desire, loss of self-esteem, loss of sexual confidence, relational problems, don't feel like a man, anxiety, depression, and too tired for sexual activity are very, very prevalent. So these are some of the things that we have to be mindful of whenever we're treating a patient who's coming in with sexual effects after prostate cancer treatments. And this is looking at different sort of treatment algorithms. So whether you have the combination therapies or different therapies alone, of course, more severe when you have combination therapies up to like nearly 100%. But even in people with monitoring alone, active surveillance, right? We haven't really done anything. You've just been given that diagnosis of prostate cancer. That alone is associated with a 50% erectile dysfunction rate. Okay, so this is some of the things that we're dealing with in the clinic. But the good news is there's people there to help, right? You're not alone. Even having the support group, I think, is like a really strong indicator that we're going in the right direction. And things like the new Share Clinic, urologists and primary care providers and others who are in this space, we're here to help. This was a landmark study. Again, it's getting old now. It's nearly 10 years old, but when it was sort of published in the New England Journal of Medicine back in 2016, it was seen as like a landmark study. And it was landmark because it was the first study that sort of looked at sexual, functional, and urinary outcomes in patients who underwent multiple different types of treatment for prostate cancer. Before this study, it used to be like, we would check it in surgery, we would check it in radiation, but we never did a study combined. So this is like a combined study. Basically, what you're seeing here is that no matter what treatment you get, you're going to have an impact on your erections, okay? And here they're using the EPIC, which is just a type of scale, but it's used in validated research. But what we're seeing is that, of course, like active surveillance will have less, but even there, right, you see this decrease, right? Even with the diagnosis, but you're getting active surveillance, and that's that psychogenic aspect of it. And then here, of course, with the treatments, whether it's surgery or radiation, it's going to go down. Now, surgery usually is a very abrupt, because again, those nerves, those blood vessels are affected immediately, where radiation, the effect takes a little bit longer. But eventually, at the course of around 5-6 years, the rates are very similar, to the point where, we tell our patients, like, yes, you may have some, initially with radiation, you may have some sparing of sexual function, but over time it will catch up to prostatectomy in many cases. And same with brachytherapy. This is after low-dose brachytherapy. Again, tends to be a bit less than external beam and surgery, but even so, it can lead to sexual dysfunction rates and erection dysfunction rates of up to 70%. And even even in those patients with fairly good pre-op function, some of them will have effect. Now, that we've been making advances in our techniques. Here we have Dr. Betheny. He was one of the pioneers bringing robotic surgery to Saskatchewan, and he, one of the reasons why the Da Vinci robotic system is great is because we are able to see those nerves better. We are able to dissect them off better and have a bit less damage. And because of that, we do see better sexual and urinary outcomes in general, right? But again, the outcomes are very dependent on the disease. So if you have more advanced disease or that prostate cancer is abutting those nerves, no matter how fancy the tool is, they still are going to be damaged, right? That doesn't matter. But that being said, the tool has helped us to be a little bit more precise with that and to try to spare those nerves where we can. But even in really large volume centers like Mayo Clinic and here Mayo Clinic and Cleveland Clinic, what we see is that open prostatectomy, robotic assisted prostatectomy, lap prostatectomy, no matter what tool you use to do the prostatectomy, you still get really high ED rates. Upwards, even in the best of hands, and these are really high volume surgeons that do pretty much, this is their entire practice, is just prostate cancer treatment. Yeah, they're getting ED rates of 50+%. Okay, so what I'm trying to convey here is that sexual dysfunction is common. And because of that, it's something that is a very important part of survivorship. And the timelines of it are variable for patients, but in general, we say in the first 4-5 months, those nerves are stretched, they're potentially damaged completely, and spontaneous recovery of erections is fairly rare, okay? Even in nerve-sparing procedures. When you get to that 4 to 12 month range, you start getting some regeneration of the nerve. You do see some functional improvement. The urinary function also improves at that time. And we see about 20 to 40% of patients who were really impacted that first 4 months will start to see some improvements, okay? It depends on the extent of the disease, how much nerve sparing or not, and what other treatments they had, if they also had hormones or radiation. And then 12 months or beyond, that's sort of when we get into like the steady state. And regeneration in studies have shown up to 4 years, but usually after 1 to 2 years, we have a pretty good idea of what the functional outcome is going to be. And that's usually when we will start making that decision, okay, if this is going to be permanent, things aren't working, then we may be looking at going on to more advanced treatments such as penile prosthetic, okay? You can have a prosthetic prior to that, but I do always counsel my patients that it's good to wait a little bit just in case you get the spontaneous recovery, okay? And usually max of 50% will recover, as was shown in those previous studies. So the factors that are associated with recovery are what was your function prior to the treatment, what is your age, which often can correlate with the pre-op function, but not always. Other health problems that may impact erections, so diabetes, high blood pressure, smoking history, etc. Nerve sparing versus non-nerve sparing, which we talked about, and then the experience of the surgeon, which is more the volume of cases. Because again, like anything, right, the more experienced the surgeon, the likely of having a better outcome, and that's just common sense. But that was shown in this landmark study that was published looking at a nomogram on erection function outcome and recovery. Murray sort of alluded to this, but we are in a state now where there are advances in prostate cancer treatment, and where we used to think we have to treat the whole gland because we're worried about leaving some prostate cancer behind, we are now getting into a new paradigm where focal therapy is becoming more and more common, okay? And there's many different energy modalities that are used for focal therapy, whether that's high intensity focused ultrasound, cryo or freeze therapy, photodynamic therapy, laser therapy, like really small brachytherapy, electroporation, or that nanoknife, or RFA. And the reason why we're able to do this now is because the technologies have improved to become more focal, safer, and our imaging has become much, much better to target these lesions, right? So we have the target, we can actually use the energy sources in a targeted way, not just cognitive, but actually like put the MRI over the treatment field and make sure we cover everything. And this will, I think, be a game changer in the future regarding survivorship, okay? It's not yet 100% prime time. That's why you're not seeing like, oh, we're offering like huge amounts of these treatments, but it is something that is it's on the horizon, I would say, within the next couple of years of being offered in Saskatchewan. Okay, so there are opportunities to go to other jurisdictions for it, but the studies, as sort of shown here, are becoming more mature. But what you're seeing is that in those studies, especially looking at functional outcomes, and it makes sense, right? Because you're sparing parts of the prostate and the nerves and the blood vessels, you're going to get better sexual outcomes. Not that they are 100%, but I mean, it's better than not. Again, focal therapy is not for everyone. Not everyone is a candidate for it. It depends a lot on your disease state, your overall PSA numbers, what your imaging looks like, etc. But I'm just letting you know that this is something that is on the horizon, and it's something that at St. Paul's is definitely something we're going to be looking at in the future. So I was privileged, or maybe a sucker, for being the lead author on our Canadian guidelines on erectile dysfunction. It was a great project. We actually did it over COVID, which was fun. But this is a sort of a exercise where we took the literature and we made statements based on studies, not based on industry sponsorship and who's telling us what we should say, more based on these are the reviews and this is what we believe based on the evidence, okay? And we use an evidence to decision-making framework, and we had sexual health specialists and methodologists from around Canada as part of this group. And these were the 5, I would say, the summary of the recommendations that underwent really rigorous review. And the ones that really relate to this group are looking at daily dose Cialis or tadalafil versus on demand. And what we found was in our review, even though a lot of people may prefer daily dose and there is benefits from a psychological and what I'd say decreasing the risk of anticipatory anxiety and that effect, but from like a pure effects on erection and whether or not erections get better or not, we see that actually there's no big difference between those two. Among patients with erectile dysfunction should low-intensity shockwave therapy, and I don't know if any of you have heard of that, but what low-intensity shockwave therapy is it's basically a machine that delivers low-intensity shockwaves, not high-intensity. Like we use high-intensity shockwaves to treat kidney stones. This is a low-intensity shockwave. They use it in physiotherapy applications and other things for tissue regeneration and vessel revascularization. And in animal studies, it's been shown to maybe be promising. But the current literature, as it stands, recommends conditional recommendation against it, especially in the prostate cancer patient population. Okay, you may see advertisements out there, that talk about, you can go get shockwave and your erections will be much better, or you can go get platelet-rich plasma or PRP shots and your erections are going to be better. Those are not proven to be helpful in studies that are well designed and executed. So they're not recommended, and they do charge patients many, many thousands of dollars to have them. So my advice to you, it is not something I would recommend, and that's based on the literature, okay? And then the other ones that are really important is the erections and what we call penile rehabilitation, or trying to get erections going as soon as possible after surgery. There may be some benefits from like a psychological perspective, but from long-term erectile function outcomes, it doesn't show a great benefit. Where we thought it did, but when we actually looked through the literature and better controlled, what I would say higher quality studies, that does not pan out. So that's something where nothing that is necessarily new, but it's important we did include that in the guidelines. So this is sort of the conclusion from this recent meta-analysis, is that there's a paucity of data, lack of data, regarding the use of shockwave for penile rehabilitation in the treatment of erectile dysfunction post-prostate cancer therapy, okay? even though they may target patients that have had treatments, such as radiation or brachytherapy or surgery, I'm letting you know that as it stands, you're wasting your money and it's not helpful for you, okay? But we do have treatments that do help, and these are some of them. So we usually use what we call a therapeutic ladder approach, where we tend to start with the least invasive and go up to the most invasive. And many of you may have tried, sort of, and we put Cialis here, but of course there's others, but PDE5 inhibitors, intraurethral alprostadil, which is Muse, which isn't used often, but it's sort of like the injection, but putting it into the urethra with a little pellet. Injection therapy, which is highly effective, but sometimes is not acceptable to the patient and does have some side effects. Vacuum devices, which can work very well, but they're somewhat cumbersome and not acceptable to some patients. All the way up to penile prosthesis, which is sort of like the most invasive, but probably also the most efficacious or most effective. Has its own set of complications. Penis is never the same after an implant. You can never have a natural erection again with an implant. It is a sort of moderate intensity surgery. So it's something that we do offer, and thank God we have coverage for it now for prostate cancer patients in this province. When I first started here in 2011, we did not. We fought the government for 8 years to get it, and finally got it in 2019. So it is covered now. Now, that being said, the wait lists are atrocious for it, but again, we do offer it, and it's covered by the government now, which is great. Some of you may have seen this pamphlet, again, sort of old school logo here, but this is a pamphlet, or I'd say guide, that myself and Nicole Baba and some others in this space developed for patients for injection therapy. Again, very highly effective, works very well, not for everybody. And then the penile prosthesis really is a surgery where there's two different types. There's a malleable type, right, which would sort of just involve these cylinders. And then there's the three-piece device that has a reservoir, cylinders, and pump. That's the sort of gold standard, or the most physiologic, or thought to be the most acceptable to the patient, because it tries to mimic real sort of sexual activity. And it's activated by pressing that scrotal pump, which then moves the fluid from this reservoir, which is sort of placed inside the body, sort of around, just in front of the bladder, to these cylinders. And then there's a release valve to bring the fluid back. So it works through a basically pressure fluid hydraulic system. But it's extremely well tolerated. Patients do great with it from a report of satisfaction. You don't see too many surgeries where you have mean satisfaction rates in the 80+%. And that's just the reality of surgery. That's why you have to have a thick skin as a surgeon. But that being said, this is one procedure that does in the functional realm. Okay, so you're seeing inflatable prosthesis tend to have mean satisfaction rates about 85 to 90%. That's in properly selected patients that have good outcomes and have realistic expectations, okay? Because after penile prosthesis, like I said, penis is not the same. People always think, oh, give me the biggest one you have. It's like, you can only size it to what the length is, right? So if you try to oversize it, obviously you can get erosion, chronic pain, other problems, right? But the fact of the matter is, because there's been issues with the erection over that time period, the penile structures have shrunk, the elasticity of the tissue has been impacted, and the penile length and girth after implant is not going to be the same as what it was prior to your prostate cancer treatments, okay? But again, we focus on functional outcomes, getting sort of that intimacy back, that functional outcome back, and that's what we sort of strive for, and we, have good results with that. And then sort of a interlude, which we'll bring into Jennifer's little talk, is the psychosocial piece, which, as a surgeon, that's not my strength, right? Obviously, we see patients, we empathize, we work on that, but really we're technicians, right? And we work to obviously provide treatments, but that psychosocial piece does require special attention and training. And I think someone like Jennifer, who has a background of social work and has worked in these types of spaces before, is great to help guide through a coaching type of way patients go through this journey, whether it's at the time of diagnosis or later on when we're looking at survivorship. And this clinic is not new, okay? We're just fortunate to be one of 10 sites in Canada that it's now been implemented in, okay? So that's the gift that we have here, but it actually started in Toronto, and this was the landmark study that brought it in, and this is from 2018. But basically it showed that this clinic and platform was highly, highly effective in terms of that biopsychosocial impact on patient care, and their overall relational and all of those psychological things, that 5 or 6 things, all showed improvement, okay, with this platform, okay? So it's not just to help with this, but it's also a great platform to link in with the community, to get educational resources, and then of course, coaching and help if you need it from the psychosocial aspect. So that's sort of where we're at now. We're just at the beginning of, I would say, the implementation. So we're part of a pan-Canadian study through Cancer Care Canada and through sponsorship through the St. Paul's Hospital Foundation and Emmanuel Health St. Paul's to be one of the sites that's going to look at the implementation of this in our Saskatchewan context. So it's a very exciting time to be part of this, and we hope that it will become standard of care for all patients in Saskatchewan as we go. So my take-home points are, and Jennifer's going to give her talk too, and it'll link in, but prostate cancer treatments affect pretty much all domains of sexual function, okay, including our psyche. And really, it's our treatment is based on the individual, on their disease, but also on the impact and what stage you are at. The biopsychosocial model of care is imperative, and that's where I think we've been doing not horribly in the bio. We can always do better, but we have been struggling with the psychosocial. So we're hoping that this new initiative we're bringing will help with that and bring that holistic piece back. And then in terms of the treatment, we went through them. We are fortunate here in Saskatchewan that we do offer the full gamut of treatment options for patients. There are some treatments that you will read about or be targeted by marketing or other things that you may read about. Beware of them. They have not been shown at this point to be helpful in the treatment, okay? So I don't want you going out and spending $6,000, $7,000 and be disappointed that you did, okay? And that's